It's nice to have these talks interdisciplinary because it really, kind of gets you a true sense of the team as we work together and help you all to get better. It really isn't a one team or a one person approach here. It's really a team effort that helps you all. And I'm sure as you all are in various stages of disease, you can appreciate this very much because I'm sure you've seen a lot of different providers and teams in the process. So today we're going to talk about RA of the foot and ankle in particular. And RA is a chronic disease. It attacks multiple joints throughout the body. It most often starts in the small joints of the hands and feet and usually affects the same joints on both sides of the body. More than 90% of people with RA develop symptoms in the foot and ankle over the course of the disease. So it's not unlikely that you'll be seeing either myself or even podiatrists or physical therapists and as I said, a pretty multi specialty group throughout the course. Rheumatoid arthritis is an autoimmune disease, and this means that the immune system attacks its own tissues. In RA, the defenses that protect the body from infection instead damage normal tissue. This could be cartilage, this could be ligaments, and it also softens the bone. How does it happen? Well, the joints of your body are covered with a lining. This is called the synovium. This lubricates the joint and makes it easier to move. RA causes an overactivity of this lining. It swells and becomes inflamed, destroying the joint, as well as the ligaments and other tissues that support it. Weakened ligaments can cause joint deformities, claw toes, hammer toes, which we'll talk about, and softening a bone, such as, or rather called osteopenia, can result in stress fractures and collapse of the bone. I have no relevant disclosures pertinent to this presentation, and if you all want to read up more on this at the end, and I'll put this up again, here's a website that you can go to, adapted from the American Academy of Orthopedic Surgery. So RA is not an isolated disease to just bones and joints. It affects multiple tissues throughout the body. It causes damage to the blood vessels, nerves, and tendons, or it can at least. Deformities to the hands and feet are the more obvious signs of RA. In about 20% of patients, foot and ankle symptoms are the first signs of the disease. RA affects practically 1% of the population, so a pretty large proportion. Women are affected more often than men, with a ratio of up to 3-to-1. And symptoms most commonly develop between the ages of 40 and 60. What's the cause? Well, the exact cause of RA is not known. There may be a genetic reason. Some people may be more likely to develop disease because of family heredity. However, doctors suspect that it takes chemical or environmental trigger to activate the disease in people who inherit RA. What are the symptoms? The most common symptoms are pain, swelling, and stiffness. Unlike osteoarthritis, which typically affects one specific joint, symptoms of RA usually appear in both feet, affecting the same joints on each foot. With regard to the ankle, you could have difficulty with inclines or ramps, and stairs are the early signs of ankle involvement. As the disease progresses, simple walking and standing can become painful. Hindfoot, and this is the heel region of the foot. The main function of the hindfoot is to perform the side-to-side motion of the foot. Difficulty walking on uneven ground, grass, or gravel are the initial signs. Pain is common just beneath the fibula, which is the small lower leg bone on the outside of the foot, if you feel that bump on the bottom. As the disease progresses, the alignment of the foot may shift as the bones move out of their normal positions. This can result in flat foot deformity. Pain and discomfort may be felt along the posterior tibial tendon. This is the main tendon that supports the arch, and this is on the inner aspect of the ankle. Or it could affect the outside of the ankle beneath the fibula, and again, it's that ball that you can feel on the outside of your ankle. Midfoot, also known as the top of your foot. With RA, the ligaments that support the midfoot become weakened and the arch collapses. With the loss of the arch, the foot commonly collapses and the front of the foot points outward. RA also damages the cartilage, causing arthritic pain that is present with or without shoes. Over time, the shape of the foot can change because the structures that support it degenerate. This can create a large bony prominence or bump on the arch. All these changes in the shape of the foot can make it very difficult to wear shoes. Forefoot. This is the toes and the ball of your feet. The changes that occur to the front of the foot are unique to patients with RA. These problems include bunions, claw toes, and pain under the ball of the foot, which is also known as metatarsalgia. Although each individual deformity is common, it is a combination of deformities that compounds the problem. The bunion is typically severe and the big toe commonly crosses over the second toe. There can also be very painful bumps on the balls of the foot, creating calluses. The bumps develop when bones in the middle of the foot, the midfoot, are pushed down from joint dislocations in the toes. The dislocations of the lesser toes, and these are the toes 2 through 5, cause them to become very prominent on the top of the foot. This creates claw toes and makes it very difficult to wear shoes. In severe situations, ulcers can form from the abnormal pressure. In this picture, you can see, the people with RA can experience a combination of common foot problems, such as bunions and claw toes, which that's what this picture shows you here. Medical history and physical examination, like in most things medicine, is paramount. So after listening to your symptoms and discussing your general health and medical history, your doctor will examine your foot and ankle. Starting with the skin. The locations of calluses indicate the areas of abnormal pressure on the foot. The most common location is on the ball of the foot. This is on the underside of the forefoot in the front. If the middle of the foot is involved, there may be a large prominence on the inside and bottom of the foot. This can cause calluses. Foot shape. Your doctor will look for specific deformities such as bunions, claw toes, and flat feet. Flexibility. In the early stages of RA, the joints will typically still have movement. As arthritis progresses and there's a total loss of cartilage, the joints become very stiff. Whether there is motion within the joints will influence the treatment options that we have. Tenderness to pressure. Although applying pressure to an already sensitive foot can be very uncomfortable, it is critical that your doctor identify the areas of the foot and ankle that are causing the pain. By applying gentle pressure at specific joints, your doctor can determine which joints have specific needs and treatment, which joints have symptoms and need treatment. The areas on the x-ray that look abnormal are not always the same ones that are causing the pain. I always tell my patients that, we treat patients, not x-rays. So even though an x-ray might show a finding, it doesn't mean that it's necessarily symptomatic to you. Other tests that your doctor may order to help confirm your diagnosis include the following. X-rays. This test creates images of dense structures like bone. It will show your doctor the positions of the bones. The x-rays can be used by your doctor to make measurements of the alignment of the bones and joint spaces, which will help your doctor determine what surgery would be best if needed. Computerized tomography scan, which is also known as a CT scan. When the deformity is severe, the shape of the foot can be abnormal enough to make it difficult to determine which joints have been affected and the extent of the disease. CT scans allow your doctor to more closely examine each joint for the presence of arthritis. It really gives you a three-dimensional picture of the bones. It doesn't really show you soft tissue very well. That's why we get to the magnetic resonance imaging or MRI scan. An MRI scan will show you the soft tissue as well, including the ligaments and tendons. Your doctor can assess whether the tendon is inflamed, which is also known as tendinitis, or torn, like a rupture. Your doctor may refer you to a rheumatologist if he or she suspects RA. Although your symptoms and the results from a physical examination and tests may be consistent with RA, a rheumatologist will be able to determine the specific diagnosis. I'm sure most of you all have rheumatologists. There are other less common types of inflammatory arthritis that will be considered. So it may not be RA, it could be something else. Although there is no cure for RA, there are many treatment options available to help people manage pain, stay active, and live fulfilling lives. Rheumatoid arthritis is often treated by a team of healthcare professionals. These professionals may include rheumatologists, physical and occupational therapists, we have one here with us today, social workers, rehabilitation specialists, and orthopedic surgeons. Although orthopedic treatment may relieve symptoms, it will not stop the progression of the disease. Specific medicines called disease-modifying anti-rheumatic drugs, or DMARDs, are designed to stop the immune system from destroying the joints. The appropriate use of these medications is directed by a rheumatologist. Orthopedic treatment of RA depends on the location of the pain and the extent of cartilage damage. Many patients will have some symptom relief with appropriate non-surgical treatment. In fact, the medications are so good these days that It's not often that we are performing, or it's not as often that we are performing surgery for RA, which is very good. So what can we do non-surgically, which is really the mainstay of treatment? Rest. Limiting or stopping activities that can make the pain worse is the first step in minimizing the pain. Biking, elliptical training machines, or swimming are exercise activities that allow patients to maintain their health without placing large impact load on the foot, such as running. Ice. Placing ice on the most painful area of the foot for 20 minutes is effective. This can be done 3 to 4 times a day. Ice application is best done right after you are done with physical therapy. Do not apply physical activity. Do not apply ice directly to your skin. Non-steroidal anti-inflammatory medication. Drugs such as ibuprofen reduce pain and inflammation. In patients with RA, the use of these types of medications should be reviewed with your rheumatologist or medical doctor, just to make sure that there's no contraindications and to check your other medications, to make sure there's no way that they would interact with them. Orthotics. An orthotic, such as, or also known as a shoe insert, is a very effective tool to minimize the pressure from prominent bones in the foot. The orthotic will not be able to correct the shape of your foot. The primary goal is to minimize the pressure and decrease the pain and callus formation. This is more effective for deformity in the front and middle of the foot. For people with RA, hard or rigid orthotics generally cause too much pressure on the bony prominences, creating more pain. A custom orthotic is generally made of softer material and relieves pressure on the foot. Braces. A lace-up ankle brace, for example, can be an effective treatment for mild to moderate pain in the back of the foot and the ankle. The brace supports the joints at the back of the foot and ankle. In patients with a severe flat foot or a very stiff arthritic ankle, a custom molded plastic or leather brace is needed. The brace can be a very effective device for some patients, allowing them to avoid surgery. And just so you know, it's not necessarily a one-size-fits-all brace. The brace you see here actually is a custom one. So, your foot shape might be different than someone else's foot shape. So you might need something that fits you. Steroid injection. An injection of cortisone into the affected joint can help in the early stages of the disease. In many cases, a rheumatologist or medical doctor may also perform these injections. The steroid helps to reduce inflammation within the joint. The steroid injection is normally a temporary measure and will not stop the progression of the disease. They can actually work for a while. There are some patients that I have that maybe they don't want surgery, or they're not quite there yet and their pain's not as severe. They maybe get one steroid injection, it lasts them a year, they come back, they get another one, and so on and so forth. It might be a nice way of managing things that's non-operative. Your doctor may recommend surgery depending upon the extent of cartilage damage and your response to non-surgical options. This is when all else fails. So what are some of the surgeries? Fusions. Fusion of the affected joints is the most common type of surgery performed for RA. Fusion takes the two bones that form a joint and fuses them together to make one bone. During the surgery, the joints are exposed and the remaining cartilage is removed. The two bones are then held together with screws or a combination of screws and plates, sometimes staples actually. This prevents the bones from moving. Because the joint is no longer intact, the surgery does limit joint motion. Limited joint motion may not be felt by the patient depending on the joints fused. The midfoot joints often do not have much motion to begin with, so fusing them does not create increased stiffness. The ankle joint normally does have a lot of motion, and fusing it will be noticeable to the patient. By limiting motion, fusion reduces the pain. Fusion can be a successful technique. However, because patients with RA also show damaged cartilage and loose ligaments, the success rate of this type of surgery is lower in patients with RA than in patients without RA. The use of neurodegeneration medication can slow the progression of the disease and impact the type of surgeries that can be performed successfully. Actually, like I said, we're performing less of them because the medications have become so good. Other surgeries. The front of the foot is where there are more surgical options for some patients. Surgeons can now perform joint sparing operations, so not fusions, to correct the bunion and hammer toes in some patients. Your surgeon will review the most appropriate options for your case. Ankle fusion and total ankle replacement are the two primary surgical options for treating RA of the ankle. Both treatment options can be successful in minimizing the pain and discomfort in the ankle. The appropriate surgery is based upon multiple factors and is individualized for every patient. It's not a one-size-fits-all, it's similar to the braces. Patients with severe involvement of other joints around the heel, or patients who have previously undergone a fusion on the other leg, may be more suited for ankle replacement. In addition, patients who have fusions within the same foot may be more suited for an ankle replacement. Newer generation ankle replacement implants have shown promising early results. Ankle replacement implants have not yet been shown to be as long-lasting as those for the hip or knee, because they really haven't been out that long. The newer generation of implants have not really been available long enough to determine how long they will last. Following ankle fusion, there is a loss of the up and down motion of the ankle. The up and down motion is transferred to the joints near the ankle. This creates a potential for pain in these joints and potentially arthritis. Patients are able to walk in shoes on flat, level ground without much difficulty after an ankle fusion, despite the loss of ankle motion. The joints in the foot next to the ankle joint allow for motion similar to the ankle joint and help patients with fused ankle joints walk more normally. The X-ray on the left here is an example of an ankle fusion from the front on the leftmost picture, or the X-ray, and the one a little bit to the right of that, shows where the placement of the screws and the plate is from a side profile. And this is basically dependent on the surgeon's technique. There are many ways to do this. The X-rays on the right, you can see a patient who had arthritis of the hind foot, and it was treated by fusing all three joints of the hind foot, the triple fusion, which you can see right here on the front and right here on the side. And an ankle replacement was done above it over here to improve mobility and avoid the severe stiffness that would result from another ankle fusion. The ankle replacement implants can be seen here, again, from the front and the side. This is the ankle replacement, and this is the fusion below it. If you were to fuse the ankle, you just have a really, really stiff foot. So we like to preserve as much motion as we can. A fusion of the affected joints of the hind foot is the most common surgery used to treat patients with flat foot or arthritis of the hind foot. A triple arthrodesis is a fusion that involves all three joints in the back of the foot, and that's what we saw on the prior slide. Occasionally, the joint on the outside of the foot is not fused if there is minimal to no involvement of that joint. And of course, this is at the surgeon's discretion and based upon the patient's problems and what specific area it's affecting. This type of fusion eliminates the side-to-side motion of the foot while preserving most of the up and down movement. If RA is only in one joint, then a fusion of just that affected joint may be all that is needed. Any fusion of the hind foot will limit side-to-side motion of the foot. This will affect walking on uneven ground, grass, or gravel. There's no method to replace the joints of the hind foot, yet at least. I think that's being worked on, actually. The top X-ray here, over time, you can see the increased stress, and it's right over here, this orange arrow, can show the increased stress is placed on the rest of the foot after an ankle fusion can lead to arthritis of the joints surrounding the ankle. This patient had pain in the subtalar joint, again, the orange arrow here, and required an additional fusion of that joint to minimize the pain. Increased stress on other joints is the most concerning problem following ankle fusion. Fusion is the most reliable surgical method to treat RA of the midfoot joints. If the shape of the foot is not normal, surgery is designed to help restore the arch and minimize the prominences on the foot. There are joint replacement implants available for joints on the outside of the midfoot. This may preserve some midfoot motion. However, the use of these implants is at the surgeon's discretion. These implants are not available for the joints on the inside of the midfoot. Although the foot cannot be returned to a normal shape, the goals are to reduce pain in the foot and improve the potential for the patient to wear more normal shoes. The choice of treatment for patients with the bunion or lesser toe deformities, like such as hammer or claw toes, again, lesser toes are the second through fifth toes, depends on a number of factors. If the disease is very mild, joint sparing procedures that preserve motion can be considered. The decision is dependent on the medication the patient is taking and the amount of damaged cartilage that is present. A fusion of the great toe may be recommended despite the fact the bunion is very mild. If there is damage to the cartilage of the great toe joint, correcting the bunion will not minimize the arthritic pain. If the RA has progressed and the lesser toes have dislocated, a complex operation to minimize the pain and restore the shape of the foot may be recommended. The operation involves fusion of the big toe and removing a portion of bone of each of the metatarsals. This surgery removes a prominent bone on the bottom of the foot that is a source of pain and allows the toes to realign into a better position. Occasionally, the lesser toe metatarsals can be preserved by shortening them to allow the toes to resume their normal position within the joints. This is not always possible, however, and the joint may have to be removed. To fix the bend in the toes themselves, the surgeon may suggest cutting a tendon or removing a small portion of the bone of the toes to allow them to straighten. Pins that stick out of the foot are temporary. They're required sometimes and they're removed in the office at a later date after healing takes place. There are some newer implants available that can be buried within the toes, which avoid the need for pins sticking out of the foot. These implants may not work if the bone is soft or if significant destruction of the joints has occurred. This operation puts a lot of stress on the blood vessels and the skin of the foot. In severe cases, the toes may not survive the operation and may require an amputation of a portion or the entire toe. This operation can provide the patient with a high level of function and the ability to enjoy a wider variety of shoe wear. And you can see in this x-ray here, the person had a pretty severe bunion over here with the great toe. All of the lesser toes, or the toes 2 through 5, have hammer toes and they're all curled over. In this slide on the right, you see that the surgeon straightened out the toe, cleaned out the joint, fused the joint, and then also cleaned out the other joints, straightened those toes, put wires in there, and these will be actually removed in probably 4 to 6 weeks, so they won't be there. The plate stays. Reconstruction of the foot does not mean a patient will be required to wear bulky and unappealing shoes every day. The patient shown here had both feet reconstructed. She's able to wear sandals and mild heels without difficulty. Although these types of shoes are not recommended all the time, they can be worn from time to time. Not all patients will achieve such an excellent result. But you see, this is nice. Everyone wants to be able to wear the shoes they want to wear and, not have to wear specific, bulky shoes or things that they don't like. So it's nice that we can sometimes get these results. Had a pretty major surgery and really is wearing, a lot of shoe wear. Many of the medications that help with RA also affect the ability of the body to heal wounds and fight infection. Your surgeon will work with your rheumatologist or medical doctor to review which of your medications will need to be stopped prior to surgery. Once the wounds are healed, the medication is typically resumed. This period of time can be very difficult for patients with other areas of the body that are affected by RA. Many fusions require at least 6 weeks of time where no pressure can be placed on the foot. We have to let the bones heal. Making appropriate preparations to ensure you have help at home is critical for success after surgery. So that's kind of everything in a nutshell. I think the take-home points are medical management, such as newer medications we have out there are very effective. So I don't want you to lose hope and think that most situations are going to end in surgery. I'd say probably most don't because of the good medications we have these days. However, if it gets to the point that you do need surgery, the surgery does work and, it is a last resort. I want to thank you for your time. And, again, this is a good kind of hub of information from the American Academy of Orthopedic Surgery, where some of this talk was adapted from.